it's, I think, there's been a little bit of buzz around the crowd about just being in person again. I don't know for everyone else how novel this is or whether some people have been doing this all along, but Dr. Forbes and I were just talking the other day about how great it is to be in person and to be able to sort of get back into throwing ideas around and everything. So I'm really grateful everybody is here. Another exciting thing about today is, this is kind of a partnership between psychology and the Canadian Institute for Military and Veteran Health Research. We've been lucky enough to, we met Dr. David Pedro a few years ago when I had just come to Queen's, and I was really impressed, and I didn't even know that they were around. Well, I wouldn't because I was new, but I was really impressed by how much they considered mental health a part of health research, and that was really exciting for us. And since then, we've been lucky enough to receive some funding that facilitated by the Institute, and I've been lucky enough to attend some talks and some conferences with military people, and to talk with Dr. Pedlar and now Dr. Forbes, and to be able to throw around some ideas about our common interests in the intersection of health and mental health, which shouldn't even be an intersection, that we shouldn't even have to talk about those as if they're different things that intersect, because as we've discussed, they're very much together. So we're very grateful to be able to put on this, to have the Psychology Distinguished Lecture Talk in cooperation with CIMVR, and we hope this is one of many such events that are going to be happening from here, because I think it's a really important, as you begin to know the military community, it's a critical population to serve, but also a very different culture than many. So I think that this is something that we can really benefit from in psychology, and hopefully they can benefit from some of what we bring to the table. So with all that aside, it's our real privilege to welcome all the way from Australia, or as I like to call it, Canada of the South. I don't know if you call this Australia of the North, but...
We will now.
We're very lucky to have Dr. Forbes as, to speak at this joint venture, because he's one of the world's leading experts on post-traumatic stress. He's a professor at the University of Melbourne in psychiatry, and the head of the Phoenix Center, which is doing a lot of really critical, important work in post-traumatic stress. He's a leader in that field, and close to my heart, a clinical psychologist who is, not only putting his academic, he's got if you look up his CV and his accomplishments, there's a long list of academic accomplishments, over 200 published papers. But what's exciting to me is that he's somebody who's translating that into policy, and really, a lot of us we publish papers and we try to publish as many papers as we can and get our grants and do our academic work. But to have somebody out there translating this into actual policy initiatives that can transform the lives of people living with post-traumatic stress is very exciting. So I'm very much looking forward to hearing what he has to say and about the work that he's doing there. And I hope that this is the beginning of a really fruitful collaboration between Australia and Kingston. Come here in the winter sometime. It's beautiful. You'll love it. Thanks, Dr. Forbes.
Thank you very much, Dr. Solomon. Thank you very much, Dr. Solomon, for that introduction, and it's a pleasure to be here, and particularly since it sounds like it's the inaugural reopening of the face-to-face process as well. So very exciting for me as well to be part of that. So look, what I will be talking about today is current and future directions in facilitating recovery in the aftermath of trauma. But I'll talk a little bit about Phoenix, Australia, who and what we are, and then just go through a series of questions. What do we know at the moment, and what are some of the key emerging areas, not only in PTSD, but in the kind of post-traumatic psychopathology space? What do we know more broadly? What's emerging more broadly? What are some of the kind of emerging phenomena that we're wanting to pay attention to? Can we prevent the development of PTSD? Can we intervene early for subsyndromal responses to trauma? And then where are we in the innovation and treatment space? Where are we when thinking about models of care, innovations in the types of treatment we provide, and also what are some of the novel interventions that are starting to show promise. So I'll go through those. There is a bit of a kind of a disaster focus and a veteran and military focus in the work that we do. So the work that I'll be describing probably has a bias towards those populations, but a lot of that is generalisable as well. We do work with a broad range of populations, but they're probably the areas we're most deeply embedded in. So a little bit about us. So we're Australia's National Centre for the area of post-traumatic mental health. And as was mentioned, we really focus a lot on the translation. We work hard around generating new evidence, but really work hard also on the translation of that evidence to policy and practice, whether that's government policy at province level or at the federal levels, or whether it's around embedding these practices and standards within clinical services. We really try and influence what happens on the ground based on the knowledge we and our colleagues internationally generate. And we do so also through being able to provide kind of training and workforce development. What do we need to know to actually then build up the skills of the workforce to deliver on those policies? And whether they be clinicians in the field or alternatively workforces that are exposed to trauma by virtue of the work they do, whether they be military defence, kind of homeland or national security, first responders, or folks in corrections, etc. Those are exposed to trauma. How do we support them and protect them in their roles? Underneath all of that, we develop the Australian National Guidelines for the Prevention and Treatment of PTSD and Complex PTSD, so the NHMRC guidelines. So our NHMRC equivalent of your CIHR. And so that really provides a benchmark then for the work we do across these agencies nationally. Just to give a shout out to my executive team, I'm kind of blessed to have a terrific executive team working with me, kind of professors across research, around policy translation, across training, workforce development, across clinical services, and of course my Deputy Director, Professor Andrea Phelps. And it's really by virtue of the fact that this is a really strong leadership team that works together that makes my job, I won't say easy, but much easier. So really appreciate the executive management team, and this is our team more broadly, distributed across those arms. And shout out to the staff at Phoenix Australia. Really important for us, I was talking about the role that we have in trying to change things on the ground nationally within Australia. A big part also is the role we have internationally. So we're deeply embedded in the International Society for Traumatic Stress Studies, at kind of past presidency roles. I'm chair of the current International Guidelines Committee around PTSD, roles on exec boards, etc. So really important for us is being able to think about what we know and make sure that that gets traction internationally. And just delighted in the military and veteran space, and appreciation for this invitation also to my colleague, Professor David Pedro, who together with me kind of co-chair of Five Eyes Veteran and Military Research and Innovation Collaborative. And Professor Pedro has been a terrific collaborator and colleague of ours for many years now, and we're deeply appreciative of that relationship. And that's just one of the meetings, one of the inaugural meetings I think we had, we gathered together the key centres of excellence across the Five Eyes countries. So what do we know now? So what we know now is that exposure to trauma is relatively common. 20 years ago, we thought that this was we used to call it an abnormal event, and any response you have is a normal reaction to an abnormal event. We now know actually exposure to trauma is a pretty common thing. Most people are likely to experience it at some stage in their lives. You know, whether that be kind of disasters, both natural and man-made, assault, sexual assault, family violence, accidental injury, most commonly transport injuries, exposure during occupations, for example, first responders and military veterans, that at some stage in their life, the majority of people are likely to encounter a traumatic experience. Really important message within all of that is that most recover. Most recover, and we'll talk a little bit about what those trajectories look like. If someone does actually develop a psychological injury that turns into a psychiatric condition, the most common ones are post-traumatic stress disorder, depression. Second level is anxiety disorders and substance use disorders. We often gravitate to the diagnosis of PTSD because it's got the PT at the front, the post-traumatic at the front, but the reality is post-traumatic depression is just as common as PTSD. So in terms of what do those trajectories look like, now this is just a heuristic, but we do have a whole range now of kind of longitudinal studies in the aftermath of exposures during war, in the aftermath of 9/11, in the aftermath of motor vehicle accident, in the aftermath of disasters, and these trajectories tend to hold up, which is what we see is the kind of green line, the recovery line, where people are feeling distressed, they're impacted in functioning, but they tend to bounce back. The brown line, which is the persisting response, impacted in functioning and stay impacted chronically in the absence of intervention. The resilient line, which we were less aware of, but it is there, the yellow line at the top, where people can experience distress and are not disrupted in their functioning and continue to function. And there was a notion for many years as though that yellow line didn't exist. But we know now, through science, through evidence, that that's a really strong line. Apart from, as clinicians, what we see are the other lines. We don't see that yellow line. When you look at population studies, that yellow line exists. And the last one is the blue one, the delayed, which is someone's travelling okay in the aftermath of trauma, and then in the context of a reminder, another stressful event, or possibly the anniversary of the traumatic event, where we see suddenly escalation in symptoms and becoming symptomatic and potentially developing a condition like PTSD. And that's probably about 5% of the exposed populations of those who develop difficulty. So we know also that the delayed exists. Again, there was some suspicion, was the delayed really subclinical problems that were there all along? But we now know actually for many people who are largely asymptomatic and then genuinely come across a trigger that just opens up Pandora's box. So what are some of the factors that we know influence which of these trajectories someone might go on? So one is pre-existing factors. So prior history of trauma, prior history of having mental health problems in the past, age, gender and other demographic characteristics can be predictive, and also poor social support. Then there's event-related characteristics, so what actually happened during the trauma, and the things that we know ramp up the toxicity of traumatic experiences, the nature and severity of those experiences, how long it went on for, the degree to which you felt your life was in danger, and we also know that interpersonal trauma is potentially more damaging than accidental or natural trauma, like a natural disaster, for example, or a motor vehicle accident. So those things increase the likelihood of having difficulties. The predictability and controllability of the events. So for predictability, for example, walking down the back streets at night of the area of town that you know to be most dangerous and being assaulted, compared to sitting in your lounge room at night watching television at home and someone coming in through the window. Even if the assault is the same, even if the technical damage is the same, the idea of predictability, that you're living in a world where you've got some sense of what might happen. So the less predictable, the more potentially, the more risk there is attached to it. And again, around controllability as well. The more sense of control the person has over that situation, the more likely it is that it's going to limit the impact. The less control, the more uncontrolled it feels. Again, higher the risk. And then the issue of, in terms of initial reactions, there's two features that we know to look out for in the aftermath of trauma. So one being significant hyperarousal, where the person's really keyed up and on edge. And for a while, kind of talking about kind of heart rates of over 90 beats per minute that persist for hours and days, that don't settle. And the other is the flip side of that, was what we call the dissociative reactions, where the person shuts down, feel numb, have a sense of being outside of their own body, time slowing down or speeding up. Both of these kinds of more extreme reactions impair processing, impair emotional processing, and can be risk factors down the track. So these are the things we're looking out for in the immediate aftermath. And social support, again, being a really important predictor, both positively and negatively. In terms of the post-event predictors, having ongoing stressful events occurring can really make recovery, adaptation difficult. And we see this commonly in disaster survivors who have managed to get through the disaster okay, but then they're dealing with the issue about having lost their job, their workplace no longer exists, as it's been either washed away by the water or blown away by the fires. They've lost their income, they're struggling with insurance companies about trying to get funding for rebuild, and all of these multiplicities of stresses then increase the likelihood of having an ongoing impact. And poor social support. Good social support being a protective factor, poor social support being a risk factor. The good news about this is that the social support post-event, when we look at meta-analyses in terms of predictive meta-analyses, the post-event social support is one of the biggest predictors we have. It doesn't outweigh the event, but it does outweigh a lot of the before characteristics, the pre-existing characteristics. And that's really good news, because that's something we can't do anything about the before, but we can do a lot about the after. So that really hones our attention to what kind of supports are delivered for people in the aftermath of events as being really strong and really important factors. So what do we know now also in terms of treatment? So let's say someone does develop a condition like PTSD, what do we know? And here the international guidelines are pretty consistent, where we've got the psychological treatments being kind of clearly first line in relation to the strongest evidence base. The class of psychological treatments we call trauma-focused cognitive behaviour therapy. There's a whole series of kind of subvariants of that, so prolonged exposure therapy, cognitive processing therapy, trauma-focused cognitive therapy, the Clark and Ellis model. And then eye movement desensitisation and reprocessing. But currently first-line psychological is still trauma-focused. First-line pharmacotherapy is the class of SSRIs more broadly, the antidepressant. Some reviews kind of argue for sertraline, others for paroxetine, but the reality is when we start to look at meta-analytic reviews of those, it's hard to distinguish between the class, and by and large it's likely to be dictated by the GP, the primary care physician, or by the psychiatrist around the individual profiles in terms of the way in which the patient might react to the side effects. But by and large the SSRIs, but the benefits are significantly smaller than they are for the psychological therapies. But there's a lot of room for improvement. So even in our psychological therapies, we're still going by the rule of thirds, which is if you get into one of these evidence-based treatments, there's about a 30% chance that you'll recover from your PTSD, about a 30% chance you'll get a lot better but still be symptomatic. There's a 30% chance the treatment's not going to shift much for you. So it really does focus our attention about saying, you know, we've got to be able to do better than this to improve outcomes for people affected by trauma. So then what do guidelines tell us upstream about universal interventions? Are the things we know we can do for people in the aftermath. So coming back to what we identified as the risk factors, things that we knew facilitated, protected or mitigated the effects of trauma, things we knew ramped up the risk. There's an approach that we would describe as kind of consistent with psychological first aid, even though we're kind of reluctant to overly package something. And the essential elements of that are providing information, providing emotional support, de-arousal strategies, practical assistance, connecting people up with supports to be able to facilitate what they need emotionally or instrumentally. Coming back to that list of risk factors, again, we're trying to intervene to mitigate some of those risk factors. The one thing we know, though, is what we're strongest on is what not to do. And there was a while, probably about 25 years ago, where, and it's still reasonably strong today in parts, psychological debriefing, the notion that after an event, it's very important for a mental health professional to rush in, get the person to describe in all manner of detail what they've experienced, what they've seen, and then what their experience of that was, what they thought, what they felt, etc., and to go through that in a lot of detail, and often to do that in a group and hear that from others. What we know now is that that doesn't prevent PTSD, and what we also know is that for some people, not all, but for some that's positively unhelpful. The reality is people react in all different ways. We've got to trust humanity. Humanity has been built to deal with adversity in life. So we've got to trust humanity to be able to bring to bear what it has to be able to people to use their natural resources to recover. For some people, they want to talk about it, and they want to talk about it with as many people as they can, in which case that's great. It may or may not be that mental health professional, it might be their family or their friends. But really allowing that facilitation of conversation really important. But for some, they want to park it, they want to get back into control, they want to get some structure back into their life. They want to be able to get a sense of control back and then be able to discuss it with whom they want when they're ready to do so. So really important is that what we don't do is prescribe anything that actually overrides someone's natural coping strategy. So what we call a psychological first aid, these interventions are evidence informed, even though the package of interventions under psychological first aid hasn't been evaluated as a package. And you know, that's obviously got its challenges in doing so, but all of the interventions within it are evidence informed. So what are some of the emerging areas of relevance in relation to the kind of post-traumatic psychopathology or phenomenology? And here we kind of think about, you know, there's been a lot of discussion about PTSD symptoms. And as we know, they're kind of largely four clusters: re-experiencing symptoms where the memory comes back in various shapes and forms, the active avoidance where the person tries to push it away, either out of their mind, push away feelings of it, or stay away from reminders. Kind of passive avoidance or negative emotionality more broadly, so a sense of numbing, a sense of kind of dysphoria, anxiety, distress, anger, guilt, a lot of the kind of negative emotional packages, and then a hyperarousal, the sense of being keyed up or on edge, with a whole range of symptoms that lie underneath that. So that's been reasonably explored. The field internationally is varied in how it's approaching this diagnostically. So DSM's kind of ramped up to more with 17 symptoms, now up to 20. ICD has taken the opposite approach, the WHO guidelines, taken the opposite approach to say, look, this isn't feasible to be able to do this on a mass scale. We want this to be as simple as possible, and kind of ramp down to a very small number of symptoms that just kind of indicative of each of these clusters. So we got a fair idea of what the breadth of the PTSD symptoms look like. Diagnostic manuals vary in how they might measure it. But what's really important is what we're observing as going across PTSD and other problems, subclinically or clinically, things that we think are really important that overlap with PTSD that are emerging. And whilst there's a myriad of those, I'm just going to pick two out to talk with you about today before I talk about intervention, and that's the issue of anger. And anyone who knows me and my work will not be surprised by the fact that I'm talking about anger. It is something I kind of feel really strongly about, kind of raising the profile around. There's about one paper on anger for every 10 to 15 papers on anxiety and depression, and rarely do they find their way into our clinical training programs as well. Anger is a problem to be assessed for and intervened for. So, and as I hope you'll see, kind of part of the data that we'll be presenting is just trying to reinforce why this is really important in our view. The other is the issue of moral injury, which I'll talk about shortly. So as I'm suggesting, anger is a bit of the neglected presence, and this is not new. So, in 1995 it was identified as a forgotten emotion. 20 years later, David Barlow identified as the kind of the unrecognised emotion in emotional disorders. And a keynote I gave for ISTSS 3 years ago talked about anger as the neglected sibling in the affect family. The belligerent sibling that no one wants to talk about, and that doesn't really find its way to the family table. So when we think about anger though, really important is that we don't think of it as inherently pathological. We can easily slip into that. Anger is a really adaptive emotion. It's there for a purpose. It mobilises us to address obstacles, to address threats. It moves us towards dealing with things rather than away from them. So it's got a very strong adaptive function. It's also a natural reaction to things like unfairness and injustice, and we wouldn't want that to be different, because again, that's what mobilises us to action. The issue becomes, though, when anger starts to occur at a frequency and intensity or duration, causing the person undue distress. It starts to interfere with their relationships and their functioning, and then also lean into the areas of aggression and violence or self-harm. So here we're starting to talk about what we call about problematic anger. Just for space, I haven't included the measure, but we have developed a measure, a brief 5-item measure around problematic anger that kind of allows for a screening cutoff that I can talk more about in questions if people would like to. But really important is distinguishing anger from violence. So violence is, violence particularly around the intention to harm. So when we're thinking about, for example, intimate partner violence, which we're talking about behaviour within a relationship that's intended to cause psychological, physical or sexual harm, includes physical violence, sexual coercion and psychological abuse, various forms of threatening, coercive and controlling behaviours. The IPV is heterogeneous. It can be driven by coercive and controlling forms resulting from power and gender dynamics. It can also be driven by situational coupled violence, more likely around emotional regulation, etc. So really important for us is here in this, what we're talking about, this instrumental aggression, which is violence driven by coercion, control and gender dynamics. That's not what we'll be talking about in this context. We're talking about coming from a clinical angle. But really important is we don't lose sight of that, and that we retain, even through the lens that we're going through the clinical angle, that violence is a choice. And that violence is something we work at directly, unequivocally, right from the outset. So if we start first, if we're talking about anger, about the post-disaster context, so we've known for a while that anger's been prominent. We see it often in news feeds. We also see it in headlines. For example, we have many bushfires or wildfires in Australia. Kind of burning with rage is a really common post-disaster headline that we see. It's also really common within police and first responders. And Professor Amy Adler and I have got a book out that kind of talk about what impact of anger in high exposure populations. But some things that have really jumped out at us from what we've learnt from what was our worst natural disaster, our Black Saturday bushfires, our worst fatalities, where problem anger was occurring at twice the rate in high exposure areas compared to low. That problematic anger had a 13-fold increase in hostile and aggressive behaviours and an 8-fold increase in suicidal ideation. Anger was also the mediator of the likelihood of developing problematic mental health responses like PTSD and depression down the track, and that women in high exposure areas were experiencing violence at 4 times the rate of those in low impact areas. So what we were seeing was the issue of kind of anger and aggression and violence really jumping off the page at us, and risks for self-harm jumping off the page at us when we start to look in more detail at post-disaster data from our study. Pivoting across to the veterans, what do we know from kind of veteran and military data? We've got the impact of combat study, which shows the doubling of rates of anger even during military service, consistent with US data around the incremental increases in anger, particularly in the context of multiple deployments. And then a transition study where we've got a large population study where we measured veterans in the first 5 years post-transition separating from service. And what we found was 30% of veterans in that 5-year period reporting anger at problematic levels, compared to 16% of those current serving. So there was a doubling in that 5 years. 14% of veterans and 7% of current personnel were reporting perpetrating physical violence, and higher levels of suicidality amongst veterans of 30% and 14% in current serving members. And we did path analyses models and found that actually anger had an influence on suicide that was working through suicidal ideation, but then on suicide attempts, but it was also there even controlling for PTSD and depression. So anger was having a contribution in its own right over and above PTSD depression on suicide attempts in current and ex-serving military members. So that could be Australian data, but we've also got the data from the US Millennium Cohort study. So 100,000 current and now ex-serving members are being tracked over time. And that tells a very similar story using the same measurement as ours. 20% of ex-serving, 12% of current serving, reporting problematic levels of anger, and finding that problematic anger is, if we're thinking about adaptation post-service, having difficulties in terms of influencing involuntary job loss, financial difficulties, homelessness, unemployment, all the things that we know are problematic in terms of adaptation post-service life, but also these are things that are risk factors for suicide and suicidality in their own right as well. And we're currently looking at a paper under review at the moment, looking at the effects of kind of military to civilian transition in that study. The other thing we know from a longitudinal study we've done with Defence, starting from the point of recruitment, is that anger starts early. So this is, for example, this is 5,000 current serving members from point of recruitment for the next 4 years. These are the different trajectories over time, assessed at 5 time points over that period. And what we see is that sleep and anger and self-blame were predictive of bifurcations in trajectories at each of those time points we assessed. Each time point, these were contributing all the way through. So what we know is even in early days, we're seeing anger as being significantly predictive in terms of adaptation. So there's a chance to get in early. And in terms of treatment, where are we in anger? The reality is it's a small base, it's small evidence base. It's kind of built largely on cognitive behaviour therapy across the population more broadly, but then adapted to the trauma context, both in terms of trauma-related themes like justice, fairness, betrayal, disrespect, alienation, a sense of being misunderstood. And a small number of trials now emerging, high-quality randomised controls, starting to kind of test different anger-based protocols. So if we're thinking in the future about where we're going, about what we build into training programs and what we try and disseminate across the field in terms of screening and assessment, we're starting to build up an evidence base for what that screening might look like and also what those interventions might look like. So I'm going to pivot a bit from anger to kind of the issue about moral injury, and there's obviously significant overlap between them. Anger is a significant part of moral injury, but when we talk about moral injury, so if we think about PTSD is a response to a life threat. It's a fear-based response in many senses. But for many of the most haunting experiences they have are those where they feel like they've been part of events that have transgressed deeply held moral views that they have about life and about their own behaviours and about others' behaviour. And there's the question about whether current treatments for PTSD adequately deal with the moral dilemmas and the moral angst that many people might experience. And if we're thinking about these transgressions, we're talking about transgressions of deeply held moral convictions by self or by other, something I did or didn't do, or something I observed someone else do or not do at critical high stakes moments. The other is a sense of betrayal by authority in a high-stakes situation where the person who had my back didn't have my back, and I feel betrayed me at a time that my life or the lives of others were at risk, by act of commission or by act of omission. And so these are the kinds of things we're thinking about when we're talking about moral injury. Part of the issue, though, as we think about moral emotions more broadly, they are the guardians of society. You know, we have these kind of moral emotions to try and hold our society together. So the kinds of moral emotions we're talking about, kind of guilt, shame and embarrassment, where I feel like I've done something wrong. Contempt, anger or disgust when we feel like someone else has. And then there's pride, gratitude and compassion where we feel like we're proud of how we or others have acted. Part of the issue that the moral injury, as this topic is being better understood, there's a kind of a raft of interest in this internationally. Part of the issue, though, is that in the current measurement, there's a conflation of the event and the outcome. Those are brought together. So really important is moving forward to be able to develop outcome measurement. We're saying, well, when someone's exposed to these potentially morally injurious events, what are the outcomes? What are the emotional outcomes, the psychological outcomes? What are the spiritual and life view outcomes that come out of these? And here we are talking about a kind of a very holistic viewpoint. And so moral injury is on a continuum from challenge to stressor to a potentially moral injurious event. For example, we're talking about something more severe. So one thing that is occurring at the moment, led by Professor Brett Litz from Boston, is the development of a moral injury outcome scale. So it's an international collaboration, which we're involved in from Australia, kind of the US through Brett, Canada through Don Richardson, through Atlas, through Simva, the UK through King's, Israel through Tel Aviv University, and through us in Australia, is developing international collaboration about developing a brief moral injury outcome scale that can be used then clinically to be able to identify what are some of the outcomes we need to be concerned about. And that's currently underway, and to flag that, we're likely to see that out in the kind of clinical community through published academic papers over the course of the next months ahead, with a 14-item scale with 2 subscales, one really around shame related and the other around trust violations. So these starting to try and get some kind of scientific measurement into understanding not only what the events are, but what the outcomes are. And this, of course, is going to dictate what interventions need to look like over the course of time. And no doubt we'll have, and perhaps something to mention here is a program that we're doing together with Atlas Institute in Canada is looking at moral injury in police populations, but working through police chaplains. Chaplains have been dealing with moral injury as part of their training. This is what they do. And trying to get their view about, you know, how do they see things through interviewing chaplains and police members to understand the chaplaincy role, and where does the role of spirituality in a holistic model of care fit into the way we think as psychologists, for example, or mental health professionals, in how we might deal with the issue of moral injury. It's not the domain of any one discipline, it's really a whole of experience consideration. So there's some kind of areas of kind of transdiagnostic importance that are starting to really emerge. And have been priorities for us. The next bit is really about approach to kind of recovery after trauma, and here we're thinking about the 3 levels. So one, what do we provide for everybody? What are the universal interventions, given that we've said the evidence is pretty thin on the ground? What are some things we can do as selective interventions for people showing adaptation difficulties but not yet developing psychiatric conditions or mental health conditions? And then what are some innovations in formal interventions? So the first question is, can we prevent the development of PTSD? So what we've seen is the large body of evidence tells us we don't have much at the moment, and there's been some pharmacological studies thinking about beta blockers, propranolol. If we give everyone propranolol and lower their heart rates, lower their arousal level, can that be protective? And there's been some mixed findings about that, and certainly nothing that's kind of taken us into what we'd be thinking about doing clinically or routinely. But there is some emerging evidence in the military and veteran space, both pre-deployment and on transition. So in thinking about the kind of the military experience where personnel are trained to attend to cues in their environment, kind of signalling threat, can be life-saving in deployment-related situations, but really maladaptive when it comes to living life within the family or within the community. And what was found by the Israeli group at Tel Aviv University was that attentional avoidance to threat prior to deployment was predictive of PTSD afterwards. So those that were assessed as having active attentional avoidance of threat-related cues more likely to develop PTSD afterwards. Also, part of the other issues that we're finding is that in the aftermath on transition, in Australia, for example, we're seeing doubling of rates in the first 5 years, 20% caseness of psychological difficulties, while in defence, 40% in the first 5 years. So we're seeing this escalation. So thinking about what can we learn, what can intervention learn from these bits of data? So the group at Tel Aviv University, Yair Bachaim, developed has kind of worked on a kind of a large body of evidence. Colin McLeod kind of initiated a lot of this about 30 years ago, which is kind of two types of attention bias training. So one is attention bias modification training, and that's seen as the example on the left. And that's an example of trying to use computer-based programs to shift someone's attention from, for example, a bias towards threat across to a bias, in this case, away from threat. But it could go the other way, and which is actually what they did. If they were saying, well, if the risk of PTSD is you've got a bias away from that, can we retrain you through a brief 10-minute computerised attention retraining program towards a bias towards threat, and is that predictive and protective? The other is attention control training, which just tries to reset you to neutral, which doesn't take a bias, it just tries to reset your attention to neutral, to paying attention to whatever's in front of you. And both of these are significant for what we'll see. So they then rolled out the attention bias modification training of biasing attention towards threat, 250 soldiers, 4 arms, big trial, and found that in the control condition, 8% PTSD down the track. So this was done 10 months prior to deployment. In the control condition, 8% PTSD. In the attention bias modification towards threat with 4 sessions, 10 minutes each, 2% PTSD. So really significant finding. It's probably the bit of the strongest data we have on a large scale in terms of what can we actually do something that's scalable to actually prevent the development of PTSD. They then also tried the attention control on ex-serving members with PTSD and said, well, can resetting attention help for those who are symptomatic? And found in Israeli veterans and in US veterans, reductions in PTSD using this computer-based program. So then, hearing all of this, the question for us was, well, if part of the problem in readjustment for soldiers is, you've trained me to be a soldier, but you've never trained me, you don't deprogram me, you don't train me for civilian life. Is at transition a really good time to be using attention control training and resetting your attention to neutral. So when you're in a job interview, you're paying attention to the interviewer, you're not looking out the window at who's walking past. When you're talking to your family members, you're paying attention to what they're saying, you're not listening out for anything, you're not listening out to the perimeter of your house. How can we help you adapt by doing things that were so deeply trained by untraining those? So we ran a pilot study looking at folks who were leaving defence, and found, to our surprise, with a small number of people, about 59, that those who received the attention control training, and the dummy treatment looks the same for the person who's doing it, they're not picking up what the underlying algorithm is that's trying to re-establish a different attention paradigm, that those who received attention control had significant reductions in their PTSD symptomatology. They weren't diagnostic, but significant reductions for those who were symptomatic. No change in the attention control. 20% of those in the dummy condition went on, even in a 4 or 6 week period, to increase their symptomatology. Nobody in the attention control condition got worse in that same period, where our longitudinal data is telling us that people are getting worse. So what was happening in the dummy condition was exactly like what we saw in our longitudinal study. The attention control was telling us something different. Obviously it needs to be replicated, but the implications of something that's non-clinical, that's scalable, that takes up 40 minutes, 10 minutes, 4 times in someone's time to potentially recalibrate attention to make adaptation to life in civilian society easier, certainly from our perspective, something that's kind of showing some promise. So in terms of, can we intervene at the next level then? For someone who's subclinical in terms of their symptomatology, can we intervene at that level using kind of transdiagnostic or kind of broad interventions? So here, there's a range of programs. So PM Plus, Problem Management Plus by the WHO. It's a brief skills-based intervention. It doesn't have a trauma component, but definitely showing promise. We developed together with a group of international experts in trauma and in disaster, what we call a SOLAR program, so Skills for Life, Adjustment and Resilience. And it's a brief, low-intensity program that really is targeted for those who are experiencing adjustment problems in the aftermath of disasters. Simple, scalable and replicable. It's kind of manualised so that it can be repeated, but something that can be delivered by primary care, by nursing care, through trained up coaches. We know that mental health workforces in the aftermath of disasters are thin on the ground. They're not only exposed themselves, but they're also overwhelmed. Can we broaden out the workforce that can provide intervention and support? And so through that process of reviewing the extant evidence about what the evidence was telling us about what brief transdiagnostic interventions would be appropriate, and through the international group, we did in collaboration. I noticed that Prince Charles was in Ottawa yesterday, if I read the news right. So this was a collaboration between us and the Prince's Trust in Australia. And so we kicked it off with his visit to Australia. So we developed the adult program with his involvement in Australia in 2016, and then at Dumfries House with him in 2017 for kids and adolescents. So we've got an adult program and a kids and adolescents program. And it really is kind of trying to do what we think is really important transdiagnostically, which is brief, simple strategies around managing strong emotions, targeting activity towards living the life that you value. What are things that are most important to you in your functionality? Being able to pick kids up from school, being able to do things that are important for my partner. And targeting those things as very specific interventions, maintaining healthy relationships, getting control over thinking, past thinking, interrupting rumination, forward thinking, interrupting worry, coming to terms with difficult experiences, so attention to write down their experience of the disaster, not exposure therapy, but just more a chance to organise their thinking and try and get some sense of a narrative, coherent narrative. And healthy body, healthy mind, which is kind of simple kind of dietary, exercise, things that are kind of good lifestyle factors. And we've now got to the point of kind of 3 published pilot studies, one in disaster-affected area, bushfire-affected area of Australia, one on the kind of climate-changed Pacific nation of Tuvalu, who've had a kind of a range of hurricanes that they experienced, and we trained up the local parishional providers in Tuvalu to be able to deliver this intervention and found it clinically effective. And also a program that's just been run in Germany as well. So we're starting to get a body of evidence now that we can intervene for those who are having readjustment problems that isn't targeted to one disorder or another, that's really transdiagnostic in its orientation and the building blocks of preventative. One is helping people get better, and second of all is to potentially prevent the escalation towards clinical symptoms and psychiatric conditions. So lastly is the issue about innovations in treatment. And here kind of to deal with the first one is if we've got a good evidence-based models, before we even talk about developing new treatments, can we package up those treatments differently to make a difference for people? And so what we targeted in the first instance was prolonged exposure therapy. So standard prolonged exposure therapy, trauma-focused therapy, kind of weekly over a course of 10 to 12 weeks. In treatment trials, obviously that varies dramatically, what that means kind of clinically, based on the complexity, severity, multiple comorbidities the person might be experiencing. But based on building on some work through Edna Foa that she published in JAMA, where she was looking at active duty personnel doing what we call massed exposure therapy. So rather than weekly over 10 weeks, what happens if we do it daily over 10 days? We know that so many folks drop out of treatment because so many things happen in their lives in those 10-week periods, and they're dealing with the thing that they least want to deal with, which is their traumatic memory. So when they're ready to roll up their sleeves and do this work, what happens if we do it intensively? We're supporting them every day and we're doing it this way. Does it make a difference? We pitched it as a non-inferiority trial, so we're not expecting it to be better, but maybe it's as good as. At least being able to then say, well, if a lot of people can't participate in PE generally, if we package it up this way and it's non-inferior, does that make it available to a greater number of people? And what we found, and kind of published this in Psych Medicine about 3 weeks ago, what we found is non-inferiority between them. That whilst the folks in the massed exposure therapy got better a lot quicker, that was maintained to 2 months, and we've got the 12-month follow-up that we're analysing at the moment. And those who experienced it weekly got better on a more dose-related effect. But by the end of 12 weeks, for the massed folks, that was 2 months post-treatment. For the weekly folks, that was 2 weeks post-treatment, they were the same. So we're confident being able to go back to our Veterans Affairs and our military services and say, look, we're confident that you can train up your people to be able to provide and make genuine options available for veterans, current serving members who are time challenged in different ways, and that the massed exposure option is a good treatment option for those who didn't want to participate. But really importantly also is what we found unexpectedly was the difference in dropout. We know dropout has been a significant factor that's challenged exposure therapies, particularly trauma focused, is we had 5% of dropout in the massed condition and about 18% in the standard condition. So being able to do it every day, we've got the same clinical outcomes, but a lot less folks were dropping out. So this really becomes something we need to bear in mind, and about approximately half have kind of lost their diagnosis within that period of time. So what it's telling us is, in being creative, we need to think about new treatments, but let's not just leave in a static state existing treatments. To be creative in understanding the challenges of different populations, can we package them up in different ways to make them available, make sure that they're as effective, and potentially increase kind of uptake and retention. So the next question then is, can we improve treatment response through non-trauma focused? If we know that a lot of people are reticent to deal with the thing that most haunts them, and understandably so, can we think about building an evidence base around non-trauma focused treatments? And something that might operate at a different mechanistic level. So here we've been really interested in looking at transdiagnostic interventions. So the Unified Protocol by David Barlow is probably one of the more evidence-based transdiagnostic approaches. It's shown good evidence for the treatment of anxiety, treatment of depression, treatment of anxiety and depression. Can it show some efficacy in the Unified Protocol in the treatment of PTSD? So we published a small pilot study that was generally showing promise, a kind of a small randomised control pilot study. And now in collaboration with the Atlas Institute, looking at a large-scale study randomised control trial where we're looking at putting it up against prolonged exposure therapy for PTSD in military veterans and first responders. The degree to which these non-trauma focused interventions work compared to our best practice standard, which is PE. And be really important for us to see how that goes and be able to offer a genuine transdiagnostic alternative. The other thing about transdiagnostics is that it's got the potential not only to offer alternative for PTSD, but given the multiple comorbidities we see in PTSD, PTSD rarely stands alone. It's often associated with anxiety, depression, substance use disorders, all manner of other features like guilt, anger, anxiety, suicidality, pain. Is it possible for us to be thinking about these transdiagnostic interventions as another way of thinking about how we're going to treat not only the PTSD, but this raft of psychopathology that we see in the aftermath of trauma? There's a little bit of work on specific comorbidities like PTSD and substance use disorders, so the COPE model is something that's showing some promise around that. There's some queries around the sequencing of treatments, PTSD and depression. Do we treat the PTSD first, the depression first? Under what conditions do we do what? But there's a raft of really important things that go together: sleep disorders and PTSD, pain disorders, PTSD, anger disorders and PTSD, things we know actually get in the way of PTSD recovery. So you look at the PTSD data, severe sleep problems, severe pain, severe anger mitigate the effectiveness of PTSD treatments. So the need for us to think about interventions for these at potentially mechanistic and underlying levels, around being able to think about it around for certain types, what are some of the interventions we might be able to consider at emotional awareness level, at emotion regulation flexibility, addressing emotional avoidance, and dealing with interoceptive and situational exposures. So part of the way forward is thinking about, can we think about what's the best sequence, what first and in what order? The other is, can we start to deal with a lot of these things transdiagnostically and deal with them at the underlying mechanism level? And the last is around novel treatments. I say the last, but I'll try and cut it a bit short for you, because when we start to get onto psychedelics, there's a potential for us to talk about this for quite a while. So what's showing promise in the novel space? There's a range of non-psychological, non-pharmacological interventions starting to show promise. There's about over 30 RCTs in this space. So acupuncture, neurofeedback, mindfulness, which I don't have there, transcranial magnetic stimulation. I'll talk a little bit about the neuromodulation interventions. Yoga. So there's a lot of interest in this space, but really where we're getting there's a lot of talk at the moment is in the area of hallucinogens. And when we're thinking about that, there's a couple of classes. One is around the psychedelics that operate through the 5-HT system, LSD, psilocybin, for example, and the dissociative anaesthetics, like, for example, ketamine, that work through the glutamatergic system. The entactogens, like MDMA, cannabinoids, and also where these have been considered, they've often been considered as standalone interventions or potentially as adjunctive interventions. The one that's probably closest to the top in relation to an evidence base is MDMA. And its generation of pro-social effects, which can make for a stronger therapeutic alliance, override some of that distress in relation to recounting traumatic experiences. It's tended to have been done as an adjunct to non-directive psychotherapy, which is okay if we can develop the affiliative response, if we can overcome some of the distress, allowing the person to go where they go and process in their own way. And the publication in Nature Medicine has made a big difference in that space in terms of ramping up the interest. Really important is that at the moment what we haven't got data on is how that lines up against our best practice treatments for PTSD. How does that line up against exposure therapy, for example? And is the combination of MDMA and exposure therapy something that could actually enhance the impact further again, which is to have all of that affect dealt with through the MDMA and then a systematic approach to exposure. The areas of ketamine and psilocybin are still emerging. Ketamine's showing some promise, but the results are still variable, and there's not too much in the psilocybin space at the moment, but there is interest. And the other emerging area is really around neuromodulation therapies, whether it's TMS, TBS, TDCS or TBS, all different variants of neurostimulation that are showing some areas of promise, again as a standalone intervention, improving working memory, improving cognitive processing, including speed of response times, or alternatively as an adjunct to psychological interventions. Neuromodulation intervention facilitating improved cognitive processing and improved working memory is that a window opening opportunity for us to be thinking about interventions at a psychological level. And all of this is really leading us to where the future really lies around a personalised medicine approach. Really being able to address the issue about what, for who and when. That we can get to the point where rather than at the moment it's which treatment are you trained in and then being able to, and then delivering that, where we really are driven then by a whole range of markers, biological, physiological markers, psychological markers, cognitive markers, affective markers. We're able to profile this and be able to have a much better way of being able to triage people to the intervention that match their unique profile of difficulties. Where we can start to really move, with all of this, the aim is to move that 30-30-30 into ideally 70-20-10 and ideally to, I won't say 100, but 95-5. We've been able to make significant inroads in other areas. PTSD and trauma-related mental health is moving, and it's moving strongly in this direction, and I'm really optimistic about the future. So thinking about this overall, can we focus on broader transdiagnostic phenomenology rather than just PTSD? Anger and moral injury, I put a bad joke in there, sleep's starting to wake up in terms of the literature. Dissociation's tending to find its feet. The area of prevention is still in its infancy, but it's growing, as you've seen some really, really interesting neurocognitive interventions, low intensity interventions, trying to prevent things before they get worse using transdiagnostic models, and a whole generation of innovation at the treatment end. New models, new interventions, and other mechanisms for dealing with underlying processes like transdiagnostic approaches. So thank you very much.
Thank you very much for that. That was really exciting and interesting. Do we have any questions? We have a little bit of time. I've got a microphone here. Okay, well, I'll lead off with one while people are forming theirs. So you mentioned early on that one of probably the best thing post-trauma in terms of people developing PTSD is social support. I noticed that was also a risk factor. And so I guess, in some sense, the people who already have social support are the ones who are least likely to become traumatized. So I noticed that in your solar intervention, there was some focus on maintaining relationships. But the fact that that's both a risk factor and a danger factor suggests that some of our people don't have any social support and have no relationships to maintain. I wonder whether part of a preventative strategy would be helping people develop social support where there was none, and if so, has there been any literature or any development on that front?
Sure, a terrific question, thank you. And if it wasn't there, it should have been in the solar slide, which is actively facilitating social support where there didn't exist. And also, when we think about social support, we often talk about it as though there's this global, but the reality is that there's social support for what purpose as well. So part of what the solar program does, and indeed the skills for psychological recovery programs do, which there's a bit of some literature around as well, is to be thinking about where is the person's gap in relation to social support. Is it someone to help them to be able to solve problems at an instrumental level? Is it someone to be able to speak to in a trusted and confidential way? Is it someone to help to facilitate opportunities for them? So agree with you absolutely, and there is an emerging literature around what kind of social support for who, where are the gaps, and how do you purpose address those gaps. The other part of the social support story is the negative social support, which is it's not about relationships or not. No relationships risk factor, good relationships protective factor, but a lot of people have in their lives social contacts or social supports that are not that supportive, and they're actually quite undermining and quite critical, and in fact we find that they are often people who don't have the supports are better off than those who actually have supports that are actively interfering with recovery in one way, shape or form or another. So you're right, the issue of social support is kind of multidimensional. There's emerging literature base, but really trying to dismantle that between what kind of social support, targeting those, and also how do you best mitigate the impacts of negative social support.
Any other questions?
Thanks for your talk. I don't know if you hear them. It was really interesting. I had a question about the moral injury that you were talking about. In both like my own research and working with people with PTSD, I often find that the moral injury is like a really strong contributor to their PTSD, and sometimes it seems to be the thing that is most distressing to them. So I'm wondering if you know about any research on whether it might be good to start with or incorporate treatment for moral injury specifically before moving into, for instance, prolonged exposure therapy. And the second part of my question is, because you showed some research on how the unified protocol might be helpful for people with PTSD, whether the unified protocol addresses moral injury at all.
So to deal with the first part, so one is if they may have a potentially a moral injury without necessarily having PTSD at all, in which case we're dealing with the moral injury straight up front, really. Where there's the PTSD and the moral injury. So currently the program, I guess the pilot program at the moment through Brett Litz, kind of puts forward the exposure therapy as the first, recognises that this is multidimensional and multi-staged. And it does the PE part in the first instance, so long as the person's overwhelmed by the fear of the memory or the horror of the memory. It's hard to process some of the broader, high-level thinking in relation to the morally injurious part. So his recommendation is exposure therapy first, to be able to at least get the narrative clear, get the memory organised. As we know, memories are so fragmented in PTSD. They're out of place, they're out of sequence, there's bits missing. To be able to do all of that first, and then bring in the intervention for moral injury piece afterwards, where the person's able to tolerate thinking about it more, and they've got a better sense of coherence about what happened, when and why. Oftentimes, in the first instance, doing the exposure therapy can bring such new light on what happened and why I did what I did or why someone else did what they did, which before what was just a blur of the point of most highest threat. What we can find is that some of those interpretations that were driving a morally injurious response kind of shift in their own right, because actually their view of the event changes. But where that's not the case, they've got a much stronger base then to deal with the moral injury component, because they've got a stronger platform to be standing on, and they can tolerate thinking about the event to work through it. So an adaptive disclosure is the intervention that Brett prescribes, and he's got a nice book out that's effectively a clinical manual on it that kind of is looking to build an evidence base. Yeah.
Okay, we probably have time for one more question before I turn it over to Dr. Pedlar.
Hi, great talk, super interesting. I'm wondering about the moral injury outcome scale. I'm kind of interested in whether or not the items on that are in relation to one specific incidence of moral injury, or if it could be adapted, or if it already addresses kind of like gradual exposure to like smaller, maybe less intense moral injuries over time. A lot of my research focuses on like healthcare and like stigma within that, so I'd be interested if like having those experiences of doctors not believing you or things like that as a type of moral injury over time instead of a big traumatic insult could be addressed with something like that scale.
Oh, look, it's a terrific question, terrific question. The moral injury outcome scale is based on the big T trauma, so to speak, because it was predicated on what's called a high stakes situation of a threat to your life or others, or where there's a significant catastrophic response as a consequence of what was done or not done. So it is, and whilst people weren't asked to name events for all manner of reasons, they were given kind of categories of response. Have you experienced an incident whereby you've done something that you wish you hadn't done, or you've witnessed others doing, etc. So that was predicated on the high stakes situation, but thematically, there's no reason why it can't be elaborated to kind of broader incidents that feel like they've had a catastrophic event as well, really, in terms of not being believed, not being supported, or feeling like whatever service has been provided to you has damaged you as the service that you trusted. So thematically, a lot of these things do expand. I'm kind of cautious in how much, because I think that there's probably ways and ways, and this in some instances might be a sledgehammer to crack a nut in more incremental adverse experiences. But I think the potential for it to lend itself to things outside of those high stakes situations is definitely there. Yeah.
Thank you, that's all right. So I just want to give Dave a quick thank you. My name is David Pedro. I'm the scientific director of the Canadian Institute for Military and Veteran Health Research. And first of all, we're delighted to be working with the Department of Psychology on this. We're back face to face, and we've already been talking about more things that we can do on campus to bring people together on subjects like PTSD, the intersection of pain and mental health, and some of the things that our colleague Kim was talking about here at the beginning. I also want to thank Laura for her spectacular PhD research that you were hearing about yesterday that we're involved in supporting as well. But I especially want to thank Dave Forbes. He's been a fantastic colleague. We've worked really closely together since 2018, working in the area of thought leadership. It's a little bit like you're seeing here. It's the opportunity to try and bring everything together to see what it means. So that's been our focus. And one of the things you might wonder is, how do you get to a presentation like this? So I think there's sort of three things. And Dave breaks those together. So one is that you have to become an accomplished researcher. So for some of us, that's a pretty hard thing to do. So that in itself is a huge achievement, right? And then for other of us, it's to be a great clinician. And that's a huge achievement too. So Dave's done both of those already, and I call that mastery. So mastery is key to really advancing the field like Dave is. But that's not all it takes. It also takes leadership. It's the person who can bring the ideas, bring people together, and find resources to build programs of research that help us all move forward. So Dave's this kind of a really super accomplished individual who's been able to really move the field forward. And so we're delighted to have the opportunity to work with him at Simber, and we're looking forward to working together more. So thank you for a wonderful talk, and thank you for our first face-to-face event today.
Thanks very much, Dave.